The reason that Mohs surgery is considered the gold standard for basal cell and squamous cell carcinomas, which are the two most common types of skin cancer, is that it allows us to remove a tumor or a cancer, but not necessarily take a lot of normal tissue with it. For example, with melanomas, there's standard margins that are taken around what's visibly on the surface. And those margins is why melanomas end up being large surgeries always. With basal cell and squamous cell carcinomas, we take a much narrower, tighter margin because we know that if we don't get it all with the first piece, we'll know where it's still positive. Traditional surgery, something gets removed, sent to a pathologist, and you don't know usually for days, oftentimes a week or more, if you've gotten it all out. Whereas with Mohs surgery, once we remove something, typically within 30 minutes or so, we're looking at it under a microscope and determining whether we got it all. And if we didn't, we know precisely where we need to go back. So instead of blindly, that's the other big difference with traditional surgery. If you have positive margins, that's usually all the information that you have. So you have no idea where it was positive. So you have to go and cut the whole thing out again. Whereas with Mohs surgery, we put dyes on the tissue so that when we're looking at it under the microscope, we know where the red edge is versus the yellow edge versus the green edge. So we can kind of map things out and know precisely if there's an area that's still positive, we can go back to just that positive area and not necessarily take a lot of normal tissue out unnecessarily. Unfortunately, insurance dictates a lot of what we can do in current medicine or healthcare. And if every single basal cell and squamous cell carcinoma, which there's about 4 million just in the US per year that are diagnosed, and there's probably more than that, but people haven't had biopsy yet. If every single cancer was treated with Mohs surgery, it would put too much of a financial burden because it is more time intensive. There are specific criteria that a tumor has to meet for it to qualify from an insurance standpoint for Mohs surgery. And kind of the short and skinny version of what the criteria, basically anything from the neck up qualifies regardless of size or whether it's a primary or a recurrent tumor. Recurrent meaning it's been treated before and comes back in the same spot. If it's not on the head and neck area, the hands qualify, and then the lower legs, because we don't have much laxity in that area. So taking a narrower margin is helpful to try to keep the wound as small as possible. If it's on the trunk or extremities, not including your hand or lower leg, then it has to either be 2 centimeters, which is, I usually tell people, about the size of a nickel, or if it's recurrent, so if it's been treated before and comes back in the exact same place, regardless of location, it qualifies. And then lastly, there are certain types of more aggressive types of basal cells or more aggressive types of squamous cells, such as poorly differentiated, moderately differentiated. And those are with squamous cells. And then with basal cells, if it's an infiltrative basal cell, regardless of location, it qualifies. And those are because those tumors can tend to be faster growing or more aggressive. Typically, as far as pre-operatively, there's very little that they have to change from their daily routine. Just a couple of minor things. We usually ask that they avoid alcohol for 24 hours because it does thin your blood. And then historically, when I got out of training 23 years ago, the standard was we would have people that were on blood thinners stop their blood thinners for about 3 to 5 days because it does typically make less perioperative bleeding. A large study that was done about a dozen years ago where they looked at about 20 to 25,000 patients who had had Mohs surgery, were on blood thinners, stopped their blood thinners, and retrospectively looking back, they found that between 2 and 3% had a major clotting event. So a stroke, a heart attack, a pulmonary embolism. And once that study came out, our kind of general rubric changed in the field, and we no longer have people stop their blood thinners because the vast majority of postoperative bleeding that we'll have after Mohs surgery is inconvenient for the patient, but it's not life-threatening, whereas a major clotting event can be life-threatening. So the only time I have people stop blood thinners now is if they're just on an aspirin just purely for prevention, but they don't have any history of heart disease or strokes, or they're just taking it because they heard that it will help prevent them from having heart attacks. In that case, then I do ask that they stop their aspirin, or typically it's a baby aspirin or an 81 milligram. We'll have them stop that like 5 to 7 days prior. But if they're on a prescription blood thinner, or if they are told by their doctor to take an aspirin every day, then we don't have them change that regimen. As far as eating, there's nothing really that we tell them. You can even eat the day of the surgery, because everything is done with local numbing, so you're not put to sleep, so you can have a full belly. You don't have to come in, hungry or thirsty, aside from alcohol. I tell people, it's like, nobody necessarily enjoys going to the dentist to have a cavity or a filling done, but having a cavity or a filling done compared to like a root canal, when we do the Mohs surgery, the whole point of it is to try to impact the body as little as possible, take off as little as possible. So when they hear surgery, they think, I'm going to be unable to do what I want to do for weeks or months, and that's not the case. Usually we tell people the day of, once they leave, that day and the next day, that they do want to minimize strenuous activity to decrease their risk of bleeding, particularly if they are on a blood thinner. But usually within a couple days, they can resume most activities. Swimming sometimes has to wait a little while as far as submersion of the wound, but even that, usually it's within a couple weeks they can get back into the pool. So typically by the time they're seeing me, they've already had a biopsy done, so they know they have a skin cancer. And then once they are brought back to the room by one of my medical assistants, I'll introduce myself, I'll take a close look with a bright light, and I mark the area that I want the medical assistant to numb. And I have a conversation very much like what we're having now with the patient, explaining what's going to happen and what they can expect. And then I go over wound care, how to care for it after they leave. And that usually takes about 10 minutes or so. And then I leave the room, and my assistant will typically numb the patient, get them ready, get them in position and so forth. And then while they're doing that, I'm seeing another patient getting them ready, and then I kind of circle back. Once they're numb, most of the time the removal itself takes anywhere from a minute to 5 minutes. It's not very lengthy. And then we'll have the medical assistant pressure for a few minutes while I'm taking the tissue to the lab and prepping it in preparation to have it processed. And then I'll come back, and if a lot of times just holding pressure, a lot of times the bleeding stops. But if it doesn't, we have cautery here, and we stop any bleeding with the cauterization. And then they get a temporary dressing put on their wound while they're waiting. In the past, in former practices prior to COVID, we would sometimes have people go back to the waiting room and sit, and then we'd bring them back when they were ready to have the results. But starting in COVID, and we just continued it, we just have the patients stay in the room the whole time, and they're welcome to have a family member with them or a friend. Usually the wait's about 30 minutes, and then I've looked at their slides under the microscope and come back in and let them know cancer's all out. Now we'll talk about whether or not we need to stitch or just let it heal naturally. If it's not all out, we take another piece, and then it's about another 30 minutes of waiting. 80 to 90% of patients clear with 1 or 2 stages. If it's a primary tumor, meaning if it's never been worked on or cut on or frozen, just a biopsy was taken, most of the time what we see on the surface is a pretty good representation of what's there. So if we don't get it with the first piece, one more piece usually takes care of it. Recurrent tumors that have been scraped and burned and frozen multiple times especially, those are the ones that can sometimes take 3, 4, or even 5 stages to clear, because the top of the tumor has been taken off repeatedly, and meanwhile the underneath part just continues to grow. And unfortunately, a lot of people come in and they say, well, I looked at Mohs surgery on the internet, and it said that for a little tiny spot, and then it shows this huge defect. And that's the exception, not the rule, as far as those patients typically have had their cancer treated multiple times inadequately and then end up finally getting Mohs surgery. So if we can start when it's small with Mohs surgery, it usually gets cleared in 1 or 2 stages. The initial numbing, I tell people, you'll feel a prick, and then you'll feel stinging or burning, usually for 10 to 20 seconds. But the Septicane that we now use, it does kick in pretty quickly. And then once it's numb, usually stays numb for a couple of hours. We're seeing you in 30 minutes or at most 40 minutes, so it hasn't worn off yet. In certain parts of the body, we'll purposely try to not continuously pump more numbing medicine because it makes you swell up more, especially like around the eyes and the lips. But if it's in an area where swelling's not really an issue, well, each time I come back, if I do have to take more tissue, I'll put more numbing in, and I tell the patients, you're not going to feel it this time, but this is just to reset the clock on when it's going to wear off. So they typically, when they have a biopsy done, they don't get those results for about a week to 10 days. So then when one of our staff members is calling them with the results, they'll then say, we're recommending Mohs surgery. You're going to get a call from the Mohs team who will then schedule it, but also go over, questions that you'll have. And that's kind of the gist. Certain areas of the body don't have much laxity or looseness of skin, like this part of your leg, your ears, your nose, this part of the nose, the scalp. So in those areas, I tell patients, if I can pinch the wound together with my fingers, I'm going to close it with stitches because it inevitably heals faster stitched than if it has to fill in and heal naturally, unless it's a really small wound. But if you can't move it with your fingers, then primary closure, meaning pulling it together with stitches, is not possible or feasible. So in that case, there are flaps, skin flaps, where you take adjacent tissue and move it, but it's still attached in some area. That's an option sometimes. And then if not, then a skin graft is an option. I'll be honest, early in my career, I closed everything with a flap, a graft, or a primary closure. And through experience, I've kind of come to find out that a lot of wounds, even sometimes fairly large wounds, if they're cared for properly, they can heal. And with a skin graft, you're dealing with the wound itself, but then a secondary wound where the skin has to be harvested from. A lot of times that can be as painful, if not more troubling to the patient than the wound was. There are some cases where a skin graft kind of has to be done if you're working around a free margin. So like the edge of the eyelid, the edge of the lip, the edge of the nostril. If you allow a wound in those areas to heal, wounds naturally contract as they heal, which a lot of times is a good thing because it means the scar ends up being smaller than the wound was that you started with because it contracts. But when you're working around a free margin, as that contraction occurs, it can distort the contour of things. So sometimes we'll have to do a skin graft near the eye just to prevent it from pulling down on the lid or from distorting the nostril. It varies a little bit surgeon to surgeon as to how many closures versus letting them heal by themselves, which we call second intention healing, versus doing a flap or a graft. In my hands, I would say I refer a patient out for plastic surgery, a reconstruction after the Mohs once or twice in maybe a 2-week period. And that's out of like 80 patients. So for a wound that is closed with stitches, patients often ask about, should I use Neosporin or Polysporin or an antibiotic ointment? For a wound that's closed with stitches, you really don't benefit from an antibiotic topically applied because there's no entry point. So it just sits on the surface and doesn't really do anything other than potentially sensitizing you to the antibiotic, and then you're allergic to it and can't use it when you need it. But in general, wounds that are stitched, as you draw skin together, those skin edges have to fuse so that you can take the stitches out. And that fusion of skin happens much faster in a moist rather than a dry environment, which goes against the old wives' tale that I've heard countless times from patients about, I was told to give it some air or let it air out. It's not, the wounds, it's not like they draw oxygen from the air. It's coming from your blood, so that's not helpful. So we tell patients, you want some type of ointment, we recommend Aquaphor or Vaseline or petroleum jelly, and then occluding or covering it with a Band-Aid or a pad that's big enough to cover the wound. Usually for patients that are not on blood thinners, we'll have them leave with a bandage and we tell them to leave that for about 24 hours. After 24 hours, it's helpful if you get the bandage wet, it'll pull off the skin more gently and not pull so much on your skin. And then we usually allow them to then shower, sometimes not submerge in like a tub, but a shower where you're rinsing it is usually fine. And then after they get toweled off, we'll have them apply, again, Vaseline or petroleum jelly or Aquaphor, and then a Band-Aid or a bandage of some sort. For wounds that are left open to heal naturally, a lot of times we will prescribe an antibiotic ointment, because in that case you do, by putting an antibiotic ointment, it melts directly into the wound and helps prevent infection. For wounds that are healing naturally or second intention healing, if you keep covering it for weeks and weeks and weeks, it is true that your body will keep making tissue there whether you want it or not. So there is a thing, some people call it proud flesh or excess granulation, where if you keep covering a wound for like 6 weeks and they come back and they've got a mound of beefy red tissue there. So we tell patients, keep covering it with ointment. And this is not for a stitch wound. This is for a wound that's healing naturally. Keep covering it as long as when you look at the wound, you appreciate there's a little indentation or divot. Once it becomes flush or level and looks more like a burn, that's when you want to let it air out or dry out. I would say as little as a week, and 90% are healed within 2 to 3 weeks. Now, lower legs can take a long time. People often say, well, my family member is 85, they're going to take a lot longer to heal. Honestly, on the head and neck area, even an 85-year-old has a really robust blood supply and a good venous drainage still. So they're not going to take that much longer to heal. Lower legs are unfortunately a different story. They can take a long time to heal, like months sometimes. It's a combination of the arterial blood supply from your heart down to like your ankle, lower leg areas. Not great typically in someone who's in their 70s, 80s, or 90s. And there's really not anything outside of major vascular surgery that will change that. So that's one thing. The second thing is the venous drainage and or lymphatic drainage. Usually people naturally have some lower leg edema or swelling at that age. And that swelling means that fluid in your tissue isn't moving. It's kind of stagnant or stasis. And that leads to a slower wound healing, because part of wound healing requires chemical mediators in our bloodstream that get sent to a wound and then gets taken away, and more sent and taken away. And on the lower leg, everything just kind of sits there. I always strongly recommend when you're trying to get something to heal on the lower leg, compressing the wound and not just covering it. So we use a stretchy tape that a lot of people are familiar with. When you get your blood drawn, they'll wrap it around your arm. That same product, we use that on lower leg wounds to compress the wound, and then we tell people to continue to use that for sometimes up to a couple of weeks. Because if you can keep compression on a wound, then it doesn't develop that edema. Now you'll still have edema in the rest of your leg, but where the wound is, if you're compressing that, then it typically does speed up the healing time some. So the biggest thing that needs to be addressed is infection. And I tell patients, everyone knows about redness, but as a wound heals, and even with stitches, it's normal to see some pinkness or redness, because with stitches, your body says there's foreign bodies there that don't belong. So you're going to have some reaction to the stitches that produces a little redness or pinkness. The bigger warning signs of infection that I tell all my patients is from a pain standpoint. A wound, the first day might be a little uncomfortable, but that should get better and better as the days go by. If you've been doing great for 4 or 5 days and all of a sudden things are really hurting, it's really touchy just to touch around the wound, that's a big red flag that they need to get in touch with us, because they typically need an antibiotic. The other that's more common knowledge is that if you start to see a lot of drainage coming out of the wound, yellow, gooey drainage, that's a big red flag too. But I think a lot of people are kind of familiar with that. But from a pain standpoint, infected wounds are never painless. So if they say it doesn't look good, but it doesn't hurt at all to touch all around it, it's not infected. And then bleeding is the other big thing. And we always go over with patients multiple times what to do if it bleeds. First 24 hours, and people on blood thinners, it can be more like 48 to 72 hours that they have to be careful, and we tell them to minimize strenuous activity, because when you do strenuous activity, your blood pressure naturally goes up. When you increase blood pressure, when you have a fresh wound, things start leaking. So from a bleeding standpoint, we go over how to hold pressure, how long to hold pressure. It doesn't have to be hard pressure, because when you've got a wound and you push hard, it hurts. So it doesn't need to be a lot of really firm pressure, but it needs to be constant. People's tendency is to just keep kind of dabbing it or wiping the bleeding that's coming out of the bandage, and that doesn't really accomplish much. So you need gentle but firm pressure, constant for 5 to 10 minutes, and that gets 99% of bleeding to clot. If they have stitches, depending on the part of the body that the stitches are in dictates when they come back to get them out. Some things on the face we'll take out in a week. Some things on the back and shoulders and tight areas, sometimes we'll leave them in for up to 2 weeks. If they are healing secondary intention or healing naturally, we give the patients an option. If they want to come back in 2 or 3 weeks and have us assess we do that. Some people that have been through this multiple times, they're like, I know what to do. I'll just call you if I need you. And I'm like, that's fine. So it's whatever they're comfortable with. But I would say most first-time patients, we'll see them back in about 2 weeks to either take their stitches out or to check the wound and see how it's progressing for them. I tell people that scars are an evolving part of your body. So if you take like a core sample of scar tissue at 1 week, 1 month, 3 months, 6 months, and a year, and then you look at that tissue under the microscope, it's going to look different in each of those stages. Once a scar gets to be about a year old, it is what it's going to be, basically, unless something is done. I mean, naturally, scars evolve over time. So most scars we don't tend to touch or do much with for at least a month, sometimes a few months, depending on the location. But then depending on what the problem is, if it's that there's a little redundant tissue as it healed, then sometimes it's just a simple fix of taking out that redundant tissue. If it's a contour issue, that can be sometimes addressed with a procedure called dermabrasion, where we literally kind of sand or scrape the skin down to level things off, or to try to make the edges of the scar less sharp so that it kind of blurs the edges to make it kind of blend better. There are some lasers also that certain offices have that can be done to kind of do the same thing that we used to have to do with sandpaper and or curettes. And then there are some silicone scar gels that I recommend frequently. Basically, it helps to mature the scar faster. So what was going to happen naturally just happens faster. So it takes the pinkness and the firmness out sooner, because all new scars on everyone, it's going to be pinker than your normal skin, and it's going to usually be firmer than your normal skin texture or quality. And then those things gradually soften and become less pink over time. Fair-skinned people like myself, our scars tend to stay pink longer. People that aren't as fair-skinned also aren't as prone to skin cancer, but typically their scars can fade in like a month or less, whereas fair-skinned people, sometimes they'll stay pink for 2 or 3 months. And these silicone scar gels help to speed up that process. So instead of taking 2 or 3 months, it might fade it in a month or so. Honestly, and I'm not trying to like inflate this, but I think that happens about once a week. And that's one of the reasons that I love what I do, because my wife was a former ER doctor, and she always would say that she doesn't get to see the follow-ups because you don't go back to the ER once you're better. And so I see patients literally, if not every day, at least a few times a week that I've seen them before. They're coming in for another surgery, and they're like, can you even find where you did the work? And I'm like, that's the goal. I think the biggest is what I briefly touched on was if they look up on the internet and they just type in Mohs surgery, the images that come up can be horrific. My daughter, when she was in high school, she was in like a pre-med club, and they asked for me to give a talk about what I do. And so I sort of previewed the talk with her, and I was showing some images of what can happen if you let a basal cell grow for 10 or 15 years. And they're pretty gruesome images. And she's like, you can't show that to my friends and classmates. That's hideous. I'm like, okay, well, I've become sort of numb to that over the years. And the classic one that I hear over and over again is the iceberg analogy, where it shows a picture of an iceberg where this much of it is above the water and this much is below. And they say that, with these skin cancers, sometimes that could be the case. So you have this little dot on your cheek, and then you end up with a hole this big. And like I said, that does happen very, very, very rarely.